So hello everyone. So in today's session, we would be discussing the answers to the ObGyn questions that came for the INI exam in the May 2025 exam. So about this paper as such, the difficulty level was not very hard in this. The questions were slightly limited as compared to the previous years. I would say the questions from ObGyn was slightly less as compared to the previous years, but the difficulty level was mild to moderate itself, except for few questions, one or two controversial, slightly controversial question, I would say. Majority of the questions were easily doable as such. So we would be discussing those questions as well. Let's discuss them one by one. Let's have a look at this question on HPV virus. Which among the following is the most common cause of cervical cancer? This is one of the easiest questions that they can ask from cervical cancer as such. This is often discussed as well. So cervical cancer is most commonly caused by HPV 16 and 18, which are taken as the high risk strains. You know, if they ask you among this, which is the most common one, most common is 16 followed by 18. And the most specific is HPV 18. The most malignant one or the most specific one is HPV 18. So these are considered as the high risk strains. So the high risk strains, apart from 16, 18, we have 31, 33, 45, 52, and 58. Whereas HPV 6 and 11 are considered as low risk strains. The majority of the vaccines target this 16 and 18, which are the most common type, such as Cervarix. Cervarix is against 16 and 18, whereas Gardasil is against 6, 11, 16, and 18. Gardasil is targeted against both 6, 11 as well as 16 and 18. The 6, 11 causes genital warts. They cause genital warts. And so when you give Gardasil, there is protection against genital warts as well. Gardasil is against 6, 11, 16, and 18, whereas you have this nonavalent vaccine, Gardasil 9, which is against 6, 11, 16, and 18, and apart from that, against 31, 33, 45, 52, and 58 as well. Yes. So let's see the other key points as well. As we just saw, the most common type is HPV 16, most specific type is HPV 18, the high risk strains, low risk strain we just discussed. This vaccine is basically derived from L1 capsid antigen. L1 capsid antigen. This question came twice for the INI exam. This is a very, very important aspect as such. You know, this viral oncoproteins, we have various oncoproteins such as L1, E1, E2, E6, E7. It is against this L1 capsid antigen that we derive this vaccine against. Whereas viral replication is basically influenced by E1 and E2. And malignant transformation is caused by E6 and E7. These are the other key points that you can know about HPV. Let's have a look at the next question. There are two questions from PCOD as such. Let's have a look at the first one. So according to the modified Rotterdam criteria, what are the criteria for PCOD? Yes, options, there were combination options as such. First, let's have a look at the Rotterdam criteria. Rotterdam includes 3 criteria. If 2 out of 3 are positive, it is considered as PCOD. The 3 criteria are, the first is hyperandrogenism. Either it can be clinical or biochemical. Clinical, such as patient can have acne, hirsutism. Next is the oligomenorrhea or amenorrhea, which is basically due to anovulation. So the patient can have irregular cycles due to this anovulation. The third criteria is presence of polycystic ovarian morphology in ultrasound. What do you get in ultrasound? You will see that there are multiple small follicles. There are multiple small follicles, which is of 2 to 9 millimeters. Ovarian volume is more than 10 centimeter cube. And the number of follicles. is more than or equal to 12 per ovary. This is what was described in the traditional Rotterdam criteria. But now there is modification that is given by the European Society of Reproductive Endocrinology. Just remember, given by the European Society, that is ESHRE, European Society of Reproductive Endocrinology. They have given the modification that there should be more than 20 follicles per ovary. With this number as 12, we were over-diagnosing PCOD cases. That's why they again increased the cutoff to more than or equal to 20 per ovary. Among these three criteria, that is hyperandrogenism, anovulation, and polycystic ovary in ultrasound, if 2 out of 3 are positive, we call it as PCOD. Please note that among these options, you would see obesity, insulin resistance. These are not part of Rotterdam criteria as such. Insulin resistance is not specific to PCOD. It can be associated with other conditions such as obesity as well. So among this answer, 2 and 3 are included under Rotterdam criteria. Yes, the correct answer is 3, which includes option 2 as well as 3. Let's move to the next question. This is a laparoscopic image of a patient with infertility with delayed cycles and free flow on chromoperturbation. So basically, patients with infertility, we evaluate for 3 things. We evaluate for ovulation, we evaluate for the tube, we evaluate for the semen analysis as well. Here they are giving you that the tubes are normal. There is free flow on chromoperturbation. Ovaries were enlarged bilaterally. What is the probable diagnosis for infertility? You can see this typical image of enlarged bilateral ovaries. This is seen in polycystic ovarian disease, especially in a setting of infertility. The most common cause of infertility as such in females is anovulation, and the most common cause of anovulation is PCOD. So the most common cause of anovulation is PCOD. PCOD, yes, again, it is confirmed by this bilaterally enlarged ovary. So any patient comes to you with infertility, we usually evaluate for the tubes, we evaluate for ovulation, and we again check the male, that is the semen analysis as well. These are the 3 key aspects for which we evaluate. For the tube, the investigation of choice or the initial investigation that we do is HSG. But if in HSG there is any abnormality, we go ahead with the gold standard investigation or the confirmatory investigation. The gold standard investigation is laparoscopy, hysteroscopy plus chromoperturbation, also known as dye test. So question has directly given you chromoperturbation as such. Next, for ovulation, the best test that you can do is hormonal test. Which hormone is measured? We usually go for progesterone test. Progesterone testing. And this progesterone is usually measured 8 days after ovulation, that is on the day 22 of cycle. Whereas the most commonly done test is follicular monitoring. Most commonly done test is follicular monitoring. Yes, semen analysis. Again, once you get abnormal semen analysis, we again repeat the semen analysis. If it is still abnormal, to see where the problem exactly lies or to understand the level of defect, we go ahead with FSH as well as testosterone levels. So semen analysis is abnormal. Repeat it once again. Still it is abnormal. Then we proceed with testing FSH and testosterone. Okay, so this is briefly about how we go ahead with evaluation. Again, this aspect is very, very important. Again, previously asked multiple times as well, HSG shows any abnormality such as tubal block. What will you do next? Do not go directly for treatment options such as IVF or tubal surgery. We will go ahead with laparoscopy, hysteroscopy, and dye test or chromoperturbation. Yes. So yes, this question did not go to that aspect. It was a very easy question as is they have clearly showed an image of PCOD where you can see the bilaterally enlarged ovary. Yes, let's move to the next question. Which of the following statements are true about the condition that is shown over here? So it is a sex-cord stromal tumor. Inhibin level is positive in this condition. CA125 is high. Called Exner bodies are seen in histopathological examination. So what can you see here? In this image, you can see a rosette of cells, a central core with rosette of cells, which is typically known as described as the Call-Exner bodies. You can appreciate the Call-Exner bodies in the image. Where do you get Call-Exner bodies? Call-Exner bodies are associated with granulosa cell tumor. You know, granulosa cell tumor is an estrogen producing tumor, and also the tumor marker that is produced by them is inhibin. Which inhibin? It is inhibin B. They often produce. So let's write the condition that you see here. This is granulosa cell tumor, which is an estrogen producing tumor as such. They produce inhibin B. The inhibin that is produced is inhibin B. Granulosa cell tumor comes under sex-cord stromal tumor. Even that statement is correct. You know, CA125 is typically produced by epithelial ovarian tumor, that is serous cyst adenocarcinoma. So serous variety of your epithelial ovarian tumors produces CA125. So among this, the correct answer is option 1, 2, and 4 is correct about this. Let's look at the other key important pathological findings that you see in other ovarian tumors that will help you to come to an answer as well. I would say these are the buzzwords that you have to remember, especially when you solve ovarian tumors. Called Exner body, as we just now saw, they are associated with granulosa cell tumor. Granulosa cell tumor. Hobnail cells are associated with clear cell type of epithelial ovarian tumor. They are associated with clear cell tumors. Walthart cell nest is associated with Brenner's tumor. Brenner again comes under epithelial ovarian tumors. Signet ring cells are associated with Krukenberg tumor. You know, Krukenberg tumor is a metastatic tumor of ovaries in which both the ovaries or bilateral ovaries are involved by these metastatic deposits. Most commonly, they arise from the pylorus of stomach. Apart from pylorus of stomach, they can arise from any other GI tumors or even breast cancer as well. So Krukenberg tumor is a rare tumor which is a metastatic tumor of the ovaries. Rinky crystals are associated with Sertoli Leydig cell tumor. Sertoli Leydig cell tumor. You know, Sertoli Leydig cell tumors are testosterone producing tumors which can cause virilization, hirsutism in the patient. Next, about Samoma bodies. Samoma bodies are associated with serous type of epithelial ovarian tumors such as serous cystadenoma, serous cystadenocarcinoma. Coffee bean nucleus is associated with granulosa cell tumor as well as Brenner's tumor. Schiller dual bodies are seen in yolk sac tumor. Yolk sac tumor, which is also known as endodermal sinus tumors. Yes, these are the key points that you can remember about the pathological findings that you see in various ovarian tumors. Very, very important as such. Yes, again, this is a clear-cut case of your granulosa cell tumor where you see this called Exner bodies. So moving to the next question, which of the following does not cause fetal bradycardia? This is actually a very easy kind of question. If you can come to the answer right by ruling out the options itself. See, abruption, fetal head compression, congenital heart block, and fever is there in the option. You know, mother has fever, the mother has tachycardia. Maternal fever or pyrexia is associated with maternal tachycardia, which can in turn lead to fetal tachycardia as well. So that is the principle of this question. Apart from this, we would see the other causes of fetal tachycardia as well. Abruption, can be associated with fetal distress, and there can be fetal heart rate, bradycardia, and decelerations. Fetal head compression is associated with early decelerations. Even congenital heart block is there. There can be fetal bradycardia. Let's enumerate the causes of fetal tachycardia. The most important cause is fever. Whenever we see that there is tachycardia, fetal heart rate is going beyond 180 beats per minute, the first thing that we check is the mother's pulse. There is maternal tachycardia. We check for other causes of maternal tachycardia as well, such as fever. Even infection, dehydration, hyperthyroidism can cause tachycardia as well. Any endogenous adrenaline or anxiety in the mother, again, there will be maternal tachycardia and fetal tachycardia. Medications and even anemia can be associated with it. These are the maternal causes. The fetal causes include, again, any form of infection, prolonged fetal activity or stimulation, chronic hypoxia, any cardiac abnormalities in the fetus, not the heart block as such, other causes of tachycardia, arrhythmias in the fetus, congenital anomalies, and even anemia in the fetus can be associated with fetal tachycardia. So now regarding the causes of fetal bradycardia, it includes hypotension, drug response, maternal position, especially when the woman is lying down straight in supine position, it can be associated with decrease in fetal heart rate as well. Even congenital heart block conditions such as SLE can be associated. Fetal causes include umbilical cord occlusion. When you have umbilical cord compression, we get variable deceleration. Fetal hypoxia, acidosis, they are associated with late deceleration, vagal stimulation, chronic head compression. Compression of the head, that is, head compression can lead to early deceleration. Even fetal cardiac conduction defects are associated with bradycardia. Yes, even if you don't remember this whole list as well, I would say that this question was an easily doable type of question, which is in the typical INI exam pattern of question, where usually the concept is to rule out and come to the answer. You know that fever is often associated with tachycardia for the mother, which even leads to fetal tachycardia as well. Yes. So yes, the correct answer is 4. Let's move to the next question. What is the minimum age for medical termination of pregnancy? Yes, what is the minimum age? Is there a minimum age for termination as such? Is there a particular cutoff beyond which you will say, no, I won't do MTP as such? See, if they had asked you what is the minimum age to give consent for MTP, yes, for a person to give consent for MTP, the minimum age is 18 years. But yes, always with this, we learn along with this that if a girl is less than 18 years, if she is minor, the consent is given by the legal guardian. Legal guardian. Suppose a girl comes to us who is less than 18, whatever the age it is, we can still go ahead for MTP provided the consent is received from the legal guardian. So please note that there is no particular age cutoff as such for MTP. But suppose if they ask you what was the age for consent, then your answer would have been 18 years. Yes, in this question, the better answer is 16 years. Again, this was one question where students were really confused about it, whether to mark 16 or 18. The best thing is, as such, there is no minimum age cutoff for MTP as such. So choose the lowest one here, that is 16 years. Let's move to the next question. For MTP, option of 2 doctors is required till what period of gestation? Direct EC question as such. You require 1 registered medical practitioner till 20 weeks, 2 registered medical practitioners from 20 to 24 weeks, and beyond 24 weeks, MTP is possible after approval from medical board. Yes, so till 20 weeks, there is requirement of 1 registered medical practitioner. 20 to 24 weeks, it is 2 registered medical practitioners, and beyond 24 weeks, MTP is done after approval from medical board. And this MTP is basically done if there is substantial fetal anomalies and the medical board is constituted by a gynecologist, pediatrician, and radiologist. Yes, these are the three doctors that constitute it. If suppose a person comes to you with contraception failure, MTP can be done only till 20 weeks. So 20 weeks is the cutoff for contraception failure. Yes, here the correct answer here is 20 to 24 weeks. Let's move to the next question. Which of the following statements are correct regarding hypogonadism in males? Which among the following is true about hypogonadism in males as such? The options were Kalman syndrome is a form of primary hypogonadism. You know, Kalman syndrome, the problem is actually at the level of hypothalamus, where you see that there is congenital GnRH deficiency, due to which the levels of FSH is low and even the level of testosterone is low in these patients. So it is not a form of primary hypogonadism which affects the testis as such. It is a form of secondary hypogonadism. It is secondary. In secondary hypogonadism, that is such as Kalman syndrome, you will see that level of FSH, LH are low. Yes, that is true. That is low. FSH, LH, even testosterone is low. Low testosterone and elevated LH and FSH indicates that problem is at the level of testis itself, which is a form of primary hypogonadism. It's not secondary. They are associated with testicular problems. That is primary hypogonadism. Clinical features may include decreased libido and infertility as well. That is again true. Kalman syndrome, we see that the patients can have infertility. Again, there can be decreased libido as well. So among this, option 2 and 4 are correct. Yes, we saw that option 1, Kalman syndrome is often a cause of secondary hypogonadism. Secondary hypogonadism is associated with low levels of LH and FSH, whereas primary hypogonadism is associated with higher level of LH, FSH, and low levels of testosterone. So you have primary hypogonadism, where the problem is basically at the level of testis, whereas secondary hypogonadism, the cause is pre-testicular, before the level of testis, such as hypothalamus or pituitary. Example for this is Kalman syndrome. Kalman, the key buzzword that often comes in the question is the patient has anosmia or color blindness as such. If the problem is testicular, we see that the level of testosterone is low, but there is high levels of FSH. Whereas conditions which is affecting hypothalamus or pituitary, you get low levels of FSH and low levels of testosterone as well. Yes, this is how you differentiate the key features here. Yes, the correct answer is 2 and 4, which is coming under option 2. So primary hypogonadism, it is testicular failure. Secondary hypogonadism is either at the level of pituitary or hypothalamus. The other key features that you see associated with hypogonadism, let it be primary or secondary, this includes low libido, infertility, even decreased muscle mass due to the lower level of testosterone. Again, the patient has fatigue and erectile dysfunction. They may be associated with hypogonadism. Yes, as given in the option, even libido and infertility can be seen here as well. Let's have a look at the next question. A 65-year-old female presents with multilocular ovarian cyst. There is ascites and omental KK. So we are basically thinking in terms of ovarian tumor. On top of that, ultrasound is showing there is solid areas and CA125 is elevated. In a postmenopausal woman, if the level is more than or equal to 35, it is taken as significant, and levels more than 200, you keep high suspicion for ovarian cancer. What is the most probable diagnosis or the most probable ovarian tumor that can be associated here? Among the ovarian tumors, especially in this age group, the most common one is epithelial ovarian tumors. And among epithelial ovarian tumors, the most common one is serous cystadenocarcinoma. And the serous cystadenocarcinoma is associated with CA125. This is the most common one, and that is the one that is associated with elevated CA125 as given in the question. Yes, the correct answer is serous cystadenocarcinoma. Whereas your mucinous cystadenocarcinoma, they can be multiloculated, but they are associated with CEA. carcinoembryonic antigen, and CA19-9. CEA and CA19-9 are the tumor markers that are associated. Granulosa cell tumors are associated with estrogen as well as inhibin. And the inhibin that is seen here is inhibin B. Also, they produce estrogen. That is why often, due to the effect of estrogen, the patient can have precocious puberty. In a small age group, maybe at around the time of puberty, patient can have precocious puberty. In a woman who is postmenopausal, due to effect of estrogen, they can have postmenopausal bleeding as well. Yes, here the correct answer is serous, attributed to, again, the age group, the high level of CA125, and this, the best answer is serous cystadenocarcinoma. Let's have a look at the other tumor markers that you can remember here as well. Patient presents to you with yolk sac tumor. We see alpha fetoprotein and alpha-1 antitrypsin. Antitrypsin are the one associated. Choriocarcinoma is associated with HCG. Dysgerminoma is associated with LDH and even PLAP, placental alkaline phosphatase. Apart from this, teratoma, which is yet another germ cell tumor, they don't express any tumor markers. Embryonal type of ovarian cancer or embryonal cell tumors. They are associated with both alpha fetoprotein and beta HCG. These are the important tumor markers that you see with germ cell tumor. Germ cell tumor, it is the most common ovarian tumor that you see as such in the reproductive age group. So suppose you have a young female, reproductive age group, they have presented to you with an ovarian tumor. These are the tumor markers that you have to focus upon. This was a previous NEET question as such. We are going to focus on alpha fetoprotein, HCG, LDH rather than CA125. So ovarian tumor as such, the most common ovarian tumor is serous type and it expresses CA125, whereas in young females, they are associated more with germ cell tumors, and you are going to evaluate her with alpha fetoprotein, beta HCG, and LDH. These are the core concepts about tumor markers that you have to remember. Let's have a look at the next question. The uterine stimulant not to be given in the management of PPH is, yes, the management of PPH, the drugs that we use is a very commonly asked question as such and often emphasized topic. Yes. So the most important drug or the most commonly the drug that you give initially. So the drug of choice or the initial drug that you give is oxytocin. Oxytocin is given for prevention of PPH and treatment of PPH. For prevention of PPH, we give 10 international units intramuscular within 1 minute of delivery. That is a part of active management of third stage of labor. For treatment of PPH, we give 10 to 40 international units as IV infusion. You are going to put it in 500 ml of saline and we give it as IV infusion. Even intramuscular route is there. We give 10 international unit intramuscular. Yes, next you have carbopros. Carbopros is PGF2 alpha. PGF2 alpha, prostaglandin analog. Carbopros is contraindicated in asthma. Usually, the next drug that we choose after oxytocin is next methergin. Third, we choose carbopros. For methergin, the contraindications are hypertension and heart disease. Finally, you have misoprostol. Misoprostol is given 800 to 1000 microgram as such, either as per oral, per sublingual or per rectal route. We don't keep per vaginal as such. We don't give PV route for PPS because it is just common sense. Due to the excessive bleeding, this drug can get just washed away. Please note, it's important that you are aware of the dosages of carbopros and methergine as well. Carbopros, the dosage is 250 microgram. It is given as intramuscular. Usually you keep on repeating it every 15 minutes, maximum 8 dose. Previous year question, so what is the maximum dose? 250 into 8 means 2000 microgram. 2000 microgram is equal to 2 milligram. 2 milligram is the maximum dose that you can use for carboprost. Maximum dose is 2 milligram. Methergine, the dosage is 0.2 milligram. We keep on repeating this every 2 hourly. The maximum dose that you give is 5 doses. 5 doses. The treatment purpose misoprostol dosage is nearly 800 to 1000 microgram. Yes, with guidelines, misoprostol dose is slightly different. As such, you can remember as a range 800 to 1000 for treatment of PPS. But carbopros and methergine is very specific and it is very important, often tested as well. Yes, please note that there is one prostaglandin analog which I did not discuss here. Dinoproston, PGE2 or dinoproston is used often with induction of labor as such. That is not usually used for management of PPS. Correct answer is dinoproston. Oxytocin, misoprostol, even carbopros, PGF2 alpha is used for management of PPH. Let's have a look at this question. An asymptomatic 29-year-old pregnant woman presents in the first trimester with urine culture shows E. coli. What is the most common complication associated? So asymptomatic bacteriuria is basically presence of a single organism in the concentration of more than or equal to 10 raised to 5 colony forming units is there. Without symptoms is taken as asymptomatic bacteriuria. Most commonly it is associated with E. coli. Yes, if untreated, this can progress further to acute pyelonephritis. The patient can go into labor as well. There can be preterm labor, low birth weight, and perinatal mortality. That is why any patient comes to you in the antenatal period, you have to ideally screen her in the first visit, and Government of India recommends that you have to keep on screening every trimester. So we usually send a urine routine for these patients, especially the mid-catch urine culture can be done for these patients to diagnose this asymptomatic bacteriuria. So here, among the various complications, the most common complication that you see is preterm labor. Preterm labor can be associated as a common complication associated with asymptomatic bacteriuria. So let's have a look at the next question. Arrange the following step in the correct sequence for taking a pap smear. So for taking a pap smear, the first thing is we position the patient in lithotomy position. Next, you are going to insert a speculum. Often we use Cusco's self-retaining speculum. After that, you are going to take the smear. Please note, we don't do a per vaginal examination. You have to take the cytology. If you do a PV, you insert your fingers, you are distorting the cytology. You will get false results as such. So we don't go ahead with per vaginal examination ever before performing a pap smear. We don't even clean the cervix and vagina with the swab before performing the pap smear. Practical point is, even if you have to do any procedures after this, first you take the pap smear, then only you are going to do any manipulation of vagina, such as maybe cleaning, draping, all those things you do after that. As such, you don't insert that betadine swab inside or even your fingers inside, because it will basically distort the cells. You will not get the correct result. So first lithotomy, then you're going to insert the speculum, then you proceed with taking the smear as such. We usually use 2 instruments for this in the conventional cytology. You have this Ayer's spatula, which has a bifid end and an endocervical brush. So among this, please note, we don't do PV. The options are lithotomy, then per speculum examination, then the Ayer's spatula. Yes, a direct ECA question. They are just testing you whether you have observed the procedure of taking a pap smear. Which of the following is contraindicated in pregnancy? In pregnancy, you know that we don't do CT scan. CT scan, or where there is high radiation exposure, we don't do such scans. You can do an ultrasound MRI, or even Doppler. All these investigations can be done. CT scan, which uses ionizing radiations. Those things are not done in the pregnancy. Even PET-CT is avoided. Even gadolinium-based MRIs are avoided during pregnancy. In pregnancy as such, X-ray exposure. Suppose a patient has one X-ray exposure. What will you do for that patient? One X-ray exposure is there. Usually the dose of radiation is very low. It does not cause harm to the baby. You will counsel the patient that there is no problem. We'll continue with the pregnancy. The maximum permissible dose of radiation, the upper limit of radiation that can happen in pregnancy, or the maximum permissible dose of radiation in pregnancy. In pregnancy is 5 rads. You know, rads is an older unit. We don't use rads now. Now we use grays. 1 rad is equivalent to 1 centigrade. So 5 rad is equivalent to 5 centigrade. Yes, 5 centigrade is the maximum upper limit of radiation that can happen safely during pregnancy. And yes, X-ray exposure and all, if they ask you, please note the radiation exposure is very low. Nearly 0.1 kind of rad is exposed as such. So you can safely continue the pregnancy. We don't do scans with high radiation exposure, such as CT scan in pregnancy. Yes, let's have a look at the next question. Use of magnesium sulfate is associated with all the following benefits except the options where neuroprotection in the fetus, prevent seizures. You know, magnesium sulfate is used for neuroprotection in the fetus as well as neuroprotection in the mother. Neuroprotection in fetus, this concept is utilized along with preterm labor, especially less than 32 weeks. We give magnesium sulfate for neuroprotection in the fetus. We see that babies who receive this magnesium sulfate, they are associated with less chance of intracranial hemorrhage and cerebral palsies. It even prevents seizure in the mother. That's a very important indication for which we use in patients with severe preeclampsia, impending eclampsia, or even eclampsia. That is why we use in severe preeclampsia, impending eclampsia, and even eclampsia. Even eclampsia. Now, about preventing the placental abruption and increasing the renal perfusion as such. What about this? So, preventing the placental abruption, the main drug that is associated is antihypertensive. High BP is responsible for the abruption. It's a major risk factor as such. So, the most important drug that you have to give is antihypertensives. But there is a trial known as MAGPIE trial. That is one of the main benchmark trials which is there. MAGPIE trial shows that there is even a slight decrease in placental abruption which is associated with magnesium sulfate. Theoretically speaking, we would say that magnesium sulfate causes a slight increase in renal perfusion, but many a times we see that that does not happen clinically. It is not clinically significant as such. So among the option D is the better answer. It rather than increasing the renal perfusion, it might not have much effect, or even there can be decrease in the renal perfusion as such that even prevents placental abruption. So this is the MAGPIE trial. Again, this question was something, the options are so close depending on the studies as is there is slight variation, but the best answer you can go ahead with is the MAGPIE trial, which shows that even there is a significant decrease associated with placental abruption as well. Yes, the better answer is D here. Answer is D. Again, this is showing you the findings of the MAGPIE trial. Placental abruption is significantly decrease. The result was statistically significant. Eclampsia, of course, it is significant. Maternal mortality, not much significant. Please note, even abruption, you have a statistically significant decrease when you use magnesium sulfate. In the kidneys, we see that it is associated with renal vasodilation. So there is increased renal blood flow, theoretically speaking, as such. But yes, in context of magnesium sulfate, it does not significantly improve the renal perfusion, GFR in preeclampsia. So yes, the best answer is it does not significantly improve. Though theoretically benefit might be there, it does not significantly improve the renal blood flow. Let's move to the next question. What is the best timing for copper T insertion to ensure good compliance under the RCH program? So usually we insert the copper T or any intrauterine device within 48 hours. This is known as postpartum insertion of IUCD. If insertion is not done within 48 hours, we wait for all the puerperal changes to come back, for the uterus to involute completely, and you're going to insert it 6 weeks after delivery. That is 6 weeks after delivery, you will insert it, which is known as interval insertion. Suppose a patient comes to you who's not pregnant. In such women, we usually insert this just after menstruation, where we are sure that she is not pregnant as such. We insert it usually between day 6 to day 10. That is within the first 7 days of the menstrual cycle. Within the first 7 days, you can insert it of the menstrual cycle where you're sure that she is not pregnant. So as per the RCH program, it can be inserted within 48 hours, which is known as postpartum insertion. It can be inserted immediately as well. This is known as post-placental insertion. Immediately within 10 minutes of delivery, if you insert it, this is post-placental insertion. Within 48 hours, this is postpartum insertion. Even within the first 7 days, it's okay, but we don't prefer to insert during the actively menstruating part as such. Usually we start inserting by day 6. Yes, even within the first 7 days of menstrual cycle, you can insert it, but the last 7 days of menstrual cycle, we avoid because of the possibility of a potential pregnancy. Yes, the correct answer here is 1, 2, and 3. Last 7 days, property insertion is not done. Which of the following is false about Turner's syndrome? The patient has a short fourth metacarpals, prominent occiput, widely spaced nipple, and webbing of neck is there. Yes, let's look into the key features of Turner's syndrome as such. In Turner's, you have this short stature where the typical karyotype is 45XO. You have short stature, webbing of neck, low posterior hairline, low posterior hairline, even flat occiput, poorly developed breast, poorly developed breast, widely spaced nipple, cubitus valgus deformity, cubitus valgus deformity, streak ovaries, and even short fourth metacarpals. Yes, all these findings are there. Prominent occiput is not associated with Turner's syndrome. Yes, so the correct answer is B. Let's have a look at the final question. A woman comes to the antenatal clinic with history of epilepsy. Which of the following anti-epileptic drug is most teratogenic as such? Among the drugs, please note that valproate is most teratogenic. They can be associated with neural tube defects in the fetus. Apart from this, levetiracetam and lamotrigine is taken as safe during pregnancy. And valproate is the most teratogenic among the drugs which is given over here. So in this, there were so many questions which are integrated kind of questions, which are overlapping with the other topics as well, like from radiology, from pharma, even from medicine as well. There was some overlapping topics from Kalman syndrome. But yes, overall, the paper was pretty doable, easy and direct, I would say. Just considering 1 or 2 slightly difficult questions, majority of the questions were very easy, pretty direct, straightforward and doable. That's all. Thank you.